This is, for example, the skater drain. Okay, and it comes exactly like this. Here we have the drain itself, and this is the plastic stiffener. This is the metal stiffener, and we here we have the needle or the trocar, which is the sharpest part of the system. Okay, so what do we do when we receive this drain? First, of course, we flush it. Then we start straightening it, as the drain cannot be inserted while it's lubed. Okay, now if we are going to use the tracker technique, we will start with this metal stiffener, and as you can see, it has a blunt end. Okay, this end is not sharp. So I insert it into the drain like this and gradually straighten the drain over the stiffener until it reaches the end. Once it's fully inserted, I lock it right here and tighten it to ensure that it's completely straight. Now the pigtail configuration is no longer present. And since I'm using the tracker technique, I'll bring in the sharp part, and please note that it's very sharp. So be careful, you could easily injure your assistant. I insert the sharp part into the metal stiffener, advance it all the way to the end, and then lock it in place. Here is the locking mechanism. I secure it with this metal component like this. Okay. Now it's locked and everything is secure. I want to show you this here. I hope it's clear. The trocar tape now extends beyond the drain tip, and it's very sharp. I can't even touch it. In other words, the trocar extends about half centimeter out, and that's exactly what we need because I'll do an ultrasound to confirm that everything is safe and properly aligned. Then I advance this sharp part straight in until I reach the collection. After confirming that I am in a good position, I'll unlock the trocar and then start pulling it out. Okay, as also I can withdraw the inner stiffener along with it. I want you to notice that as soon as I remove these components, the pigtail forms on its own. Okay, so the pigtail is spontaneously forms inside the collection. Okay. There is a very important point I want you to understand. It's essential that all the pigtail holes remain inside the collection. For example, if we have one collection here and another one there, in this collection the pigtail is formed with all its holes well positioned, making it ideal. But if a hole lies outside the collection, fluid will drain through it and collect outside the intended cavity. So none of the holes should lie outside the collection. All must be stay fully inside. Okay. Another point I want you to notice is that the pigtail is formed on its own. I mean that this locking mechanism allows the loop to increase slightly. Okay, if I tighten it like this, the loop becomes more pronounced. See? So it's not recommended to over tighten the string because this may cause additional unnecessary looping of the drain itself. Therefore, there is no need to tighten the string extensively. Just only tighten it until the normal shape is properly formed. Then lock the drain in this manner, and the drain will stay securely in place. So this is everything regarding the trocar technique. Now, what about the Seldinger technique? This technique is very similar to the one used for vascular access. If we have a collection here, instead of inserting the drain directly into it, I'll first insert the coaxial needle to gain access, then pass a wire through it. After that, remove the needle, leaving the wire in place like this. Okay. Now I'll no longer need this trocar. I may need the inner stiffener. Okay. The inner metallic stiffener like this one. Okay. Or I may use a plastic stiffener like this one. Actually, in most of our work with Seldinger technique, we use a plastic stiffener because a stiff wire is already in place and the tract can be dilated using dilators. So we don't need a very strong stiffness for inserting the drain. But of course, if you are advancing through fibrous or tough tissue, you can use a metallic stiffener. So we introduce the plastic stiffener until it reaches the end, and then we lock it in place. There is an opening right here. We insert it over the wire and advance the drain until we reach inside the collection. We ensure that the side holes lie completely within the collection. Okay, then we withdraw everything, the wire, the stiffener, and as you can see, the big tail forms on its own inside the collection. So this is the Seldinger technique versus the Turker technique. I'm not, of course, demonstrating the practical steps here, as we will cover it later when we start reviewing cases. I just want you to understand the difference between the two techniques. Again, which is better? This depends on your level of comfort. Some people feel comfortable about using the Turker technique. Others prefer to use the Seldinger technique. Usually in IR, use the Seldinger technique more because it aligns better with the techniques used in other procedures. People who do body imaging and body interventions may find the Turker technique more comfortable because it involves only one step: gain access, remove the trocar, and the drain forms inside immediately. Okay, without needing to insert a wire like the Seldinger technique. This varies from one person to another, but in general, the trocar technique is more suitable for superficial collections with no critical organs nearby. The issue with the trocar technique is that it's more traumatic. Okay, so if there is a bowel right here, okay, like this, adjacent to this collection, you shouldn't use the trocar technique because it carries a high risk of bowel perforation when accessing the collection, and this could lead to serious complications. Thus, the Seldinger technique is more suitable for deeper collections where there are many critical organs that could be accidentally injured. It's safer to insert a needle first, then place a wire rather than entering directly with a trocar. Okay. Now, let's talk about the maintenance of the drain. After I have successfully inserted the drain into the collection, what comes next? First of all, do we connect this drain to a drainage bag or to a negative suction? The most common negative suction is the pulp. Okay, it's a pulp-shaped container like this, and when we press it, it collapses, and then it's connected to the drain, so that when releasing the pulp, a negative pressure is created that facilitates fluid drainage. This depends on the nature of the collection to be drained. For example, if we are collecting or draining hematoma or abscess, we usually use a pulp suction or a negative suction because these collections are thick. So negative pressure facilitates their evacuation. But if a patient has, say, simple obstructive hydronephrosis or biliary obstruction, we usually use a bag for drainage. Okay, this bag or drains the collection or the urine, and since urine and bile are continuously formed, we simply need to divert the drainage only away from its natural pathway into an external bag. Okay, another common question is about flushing. When should we perform drain flushing, and what exactly does flushing mean? Okay, let's assume we are placing a drain inside a collection like this. Okay, and this collection consists of, say, blood or pus or even thick bile. Because of the viscosity of these fluids, the drain may become clogged. That's why we use a syringe containing 10 cc saline. Okay, and we connect the syringe to the catheter and inject the saline to make sure that the drain is patent. Okay, as if we are cleaning it out. Okay, typically flushing is done once daily or twice daily if the collection is thick. But do we need flushing in all cases? The answer is no. If the drainage is purely serous, with no risk of catheter obstruction, flushing is unnecessary. Let me give you an example in PCN cases. After placing a drain in the kidney, we usually recommend flushing for the first 3 to 5 days when the urine is still bloody. This prevents the clot formation and subsequent drain occlusion. Then, when the urine clears, we don't need to flush anymore. We just instruct the patient to come every 3 months to replace the drain with a new one. Okay. Now, I want you to know a very important point is the difference between flushing and irrigation. Okay, flushing means injecting saline inside the drain and stop at this point. I don't inject and aspirate. If I inject and aspirate, this is what we call irrigation, okay? And using irrigation is not recommended because repeated injection and aspiration can cause irritation and may precipitate sepsis. So during flushing, all we do is inject 10 cc saline and then reconnect the drain to the bag or the bulb exactly as it was, nothing more. Okay. Also keep in mind that flushing is a painless procedure. So if pain occurs during flushing, this indicates a problem. The patient may need to go down to the IR, okay, for drainage check, where we place the patient under fluoroscopy, inject contrast, and observe what's happening. Sometimes the drain may shift out of position like this, for example. This means you are no longer injecting into the cavity, but into the peritoneum, which explains the pain. So the presence of pain during flushing is an indication to perform drain check. Now, a crucial question is, how can I tell if the drain is functioning or not? This is a key clinical question, and you will be asked this question on the floor. If you didn't include clear recommendations, the floor team will contact you to ask how to determine whether the drain is functioning or not. The key features to assess are the drain output and the patient's clinical status. That's why nursing staff are always requested to record the daily output, and we also monitor the patient for clinical signs like fever or tachycardia, for example. We follow this up. Let's assume that on day 1 the output was 50 cc, on day 2 become 40 cc, then third day 30 cc, fourth day 20 cc. Also the patient white blood cell count is trending down and no longer febrile. In this situation, we are heading in the right direction. The collection is draining, the patient is improving, so the drain is functioning properly. On the other hand, if they tell you that the first day was 50 cc, second day 40, but on the third day it dropped to 0, and the patient is still high fever with rising white blood cell count, then on the fourth day it's still 0 with further elevation of the white blood cells and worsening fever, then something is wrong. The drain may be clogged even though flushing was performed. A small amount of thick debris may have blocked the side hose, and as a result the drain is no longer functioning. So if there is an abrupt cessation of drainage, we request a CT scan to assess drain position and determine whether the collection has resolved or persists. Okay? Okay, now, how do we know that the drain is no longer needed and we need to take it out? There are several rules for this, but the most common and the one we usually include in recommendations is that if the output is less than 10 cc for 48 hours, okay, this is an indication that the collection has been drained. Okay, of course, provided that the patient clinical status is improving. Okay. So, if drainage decreases from 100 cc to 5 cc over 48 hours with resolution of fever and normalization of white blood cell count, then it's safe to remove the drain. On the other hand, if output was 5 cc for 48 hours, okay, but the patient remains febrile, okay, we must consider whether the drain is effectively evacuating the collection or if it is obstructed. And in that case, the patient should undergo CT scan for further assessment. Now, what if we decided to remove the drain? When should the drain be removed? Assume we have a superficial collection like this that has resolved and the patient has improved and the drainage has ceased. The drain can be removed and the skin tract will close spontaneously. In other cases, we must wait for something called tract maturation, which is a critical concept I want you to understand. Okay, so let's assume that we have a biliary drain. This is a liver with dilated bile ducts, And here we have the abdominal wall. The drain is placed as shown. Okay, and for the drain to reach its target, it has to pass through a tract. This tract is created through the liver, okay, and abdominal wall. If the drain is removed on, say, day 2 or 3, bile it can leak through the tract, and instead of going out through the drain, it will go down into the peritoneum, resulting in biliary peritonitis. Okay, the only way to prevent this complication is to leave the drain in place for a while. Okay, until something called tract epithelialization occur. Okay, epithelium tissue will be here. Okay, once mature, after drain removal, bile rather than leaking into the peritoneum will exit through the skin normally. Okay, it takes 1 or 2 days. We all we do is simple dressing is applied and the tract loses spontaneously over time. But how long does it take for a tract to mature? It varies according to the procedure. In general, for biliary and cholecystostomy drains, typically it requires 3 to 4 weeks, with longer duration preferred to ensure adequate tract maturation. Okay, but for nephrostomy tubes, tract maturation is usually faster. Sometimes 2 weeks are enough, others say it takes 10 to 14 days is sufficient, though adequate time should still be allowed to ensure proper maturation. For external abscess drains, tract maturation usually takes 2 to 3 days, sometimes up to a week. Thus, the duration for tract maturation depends on the procedure type. Finally, how is drain removal performed? This is a critical point as not everyone is familiar with how IR drains work. Okay, as we mentioned before, after drain placement and pulling the locking string, the catheter become locked. The string is then coiled and secured, preventing a big tail uncoiling and unintentional drain removal. Okay, if someone attempts to remove a drain without understanding the locking mechanism, and I have seen this before, okay, forcible pulling can cause severe trauma to the liver or the organs, leading to major complications. Okay, and again, I have seen this before. Therefore, the drain must be unlocked first. Okay, this can be done by removing the locking part, but in practice, when the drain is no longer needed, we simply cut it at this point. Okay, like this. We'll cut it here. Okay. Once cut, the locking string is released, rendering the drain unusable, of course. But as we pull, the big tail straightens like this. Okay, since the string is now loose. Another key point when pulling the drain, the string often remains inside. Always ensure the string is removed along with the drain, as some may forget it. So again, please always remember this. Okay, and this string to be removed, the string forms a loop. Grab one end like this and gently pull out slowly. So as you can see, understanding how IR drains work is essential for safe and proper removal. And with that, we have reached the end of this episode. I hope you found it helpful and informative. See you next episode. Thank you.